So Professor Massard couldn't come, and then I told Mr. Kalkar that you have to present this talk. And so I was awake all night trying to find out what are the updates in chest wall resection and reconstruction since when I presented this talk, I think 3-4 years ago in the university, and I could not find much innovation or updates. So I'm afraid it is a similar talk, and number two, I was sleeping at about 12 o'clock. I didn't have time to prepare it again, so apologies. So it is the same talk which I gave 2-3 years ago, but I hope you will bear with me. Right. So we all see cases like that, and these one very, very subtle, okay? These looks really horrible. And then they are a little bit more complex, which, as we discussed this morning, that requires multiple specialties to be involved, spine, a little bit the outlet area. But the one thing common about all these tumors is that majority of them are resectable, okay? Unless they have spread far and beyond the confine of the chest, they have metastasized, they are resectable. And obviously, with something which has grown that big, has to be confined to the chest, okay? Otherwise, the patient would have been dead by now. So the results are very, very gratifying if we follow certain principles and if we have that sort of a collaborative approach as we discussed this morning. So majority of them are primary chest wall tumors, but you occasionally will find some metastatic deposits, some local recurrences of the breast carcinoma, for example, and about 5% of lung cancer will be invading the chest wall. And they are very rare. They are very uncommon, and because they are uncommon, there's often quite a bit of delay before somebody actually does a chest X-ray and find, oh gosh, there is a big mass in the chest, and let's get it investigated properly. Now, I'll be just concentrating on the primary chest wall talks, and if it is a primary chest wall tumor, then the approach is that it has to be discussed in a sarcoma team, and they will definitely advise a biopsy. Majority of them will have a biopsy, and it is important how you biopsy, take a biopsy of that area, because you will like to have that area included in your resection when you're taking a biopsy. So you need to have some sort of understanding with the person who's taking a biopsy that try to make the incision which can be incorporated in the incision which you are going to give. And there will be some occasional tumors which are so bad, fungated, growing, causing so much of distress to the patient that you may actually like to undertake a palliative resection. Now, the important thing is that we should consider the chest wall as a pretty much a dynamic organ. Okay, it not only protects the lungs and the heart and other areas, but it helps you to ventilate. Okay, and it is a very complex interplay of bones, muscles, cartilage. And that is the reason that I don't have any update to tell you, well, this is a prosthesis you put in the chest and patient will have a normal ventilation. Okay, that's a problem. But what we can do is we can mitigate the damage we're going to cause to the chest by removing huge amount of chest wall and then trying to reconstruct it in such a way that at least there is a bit of a stability. There's some semblance of functional integrity after we have done the bits with it. And then we need to be mindful of the diaphragm, the nerve supply to the diaphragm. If you're removing a huge amount of chest from one side, try not to damage too much of a diaphragm, and try to make sure that you don't damage the phrenic nerve. And then obviously there's a spine and some other structures around. So the principles are, the one most important is that the tumor has to be resectable with wide, clear margins. And the more aggressive the tumor is, the wider the margin have to be. So that is the most important. And number two, this is a new addition, and that's the only update I have in the last 3 years, because I'm looking at 2 or 3 cases where actually that was not done. And particularly with the chondrosarcomas, they are absolutely curable if you conform to that wide margin, and you do not break into the tumor and cause the spillage. So en bloc resection, not 1 rib, 2 rib, 3 rib. No, it has to be en bloc with the whole tumor. And for that matter, you need to have a very good preoperative planning, and that's where the little bit of update is, that you can sit with the with your radiology colleague, and he can give you a very clear idea, looking at the 3D formatting and other stuff, where the tumor is, what needs to be resected, do you need a help of spinal surgeon or a vascular surgeon or somebody else? And you can't have a frozen section, okay? So right from the outset, you need to know where your incision is going to be, how much you're going to take out. You just cannot take a bit out, send a frozen section. No, you can't. The bone cannot have a frozen section done. So you need to have a very clear idea at that stage what is going to come out. And once you have made a hole in the chest, then you need to reconstruct, as I said, not only to protect the organs inside, but also to maintain the functionality, to have a good respiratory mechanic. And once that is done, the important bit is the soft tissue coverage. I think that was dealt with this morning by Mr. Patel, that you have to cover whatever you put in, whatever stuff you get in, whether that's metallic, whether that's biological mesh, whether that's a Marlex or whatever, it needs to be covered with a very good, well-vascularized soft tissue, okay? And that is what makes a difference to the outcome, and that's my strong belief about it. And then you need to close the skin. So, as I said, remember about the stability of the spine. You're taking a lot of ribs at the back. Remember, that is supporting the spine, so you have to be careful about that. And then obviously, the tip of the scapula, the clavicle, the costal margins. So you just keep that in mind. You're taking lower ribs out. You're taking a costal margin out. You're taking a part of a diaphragm out. How are you going to reconstruct all of that together? Have that sort of a three-dimensional picture in your mind when you're doing that. And I've already alluded to that. And then have a prosthesis which sits in nicely and not moving in and out with each breath, but at the same time, it is not sitting so tightly that whenever a patient tries to cough or sneeze or do any movement, that it rub against the margins of your defect. And that is important. Okay, otherwise, a lot of foreign material is going in, you don't want to get it infected. So although you're covering it with a soft tissue, but still make sure. And cosmetic result, you're playing with the chest of a young person. You need to make sure that it looks good. It looks presentable when he takes off his shirt and goes for a swim or something. So that is important. Don't create a huge hills and troughs and stuff like that, which looks ugly. So you know what the histology is, because that is going to dictate what you're going to do. Some tumors like Ewing sarcoma have a different protocol. They need to be treated with chemotherapy before you take it out. Chondrosarcoma, as I said, depending on what grade it is, that will dictate what your margins of resection are going to be. So histology is important. What sarcoma MDT tells you is important. And then just like any other major operation, you need to assess the patient for fitness for surgery. And then, as I said, imaging is important to know the extent and the relationship, and also to look at the vascularity of the soft tissue flaps. So important, I think I don't have to go through that, but this is important. Entry into the chest. Where is your first incision going to be? You don't want to give incision right onto the tumor. Okay, that is important. And I don't want it to make complicated either by putting in a scope in and things like that. You don't have to do that. Really, you just sit with your radiologist. You know where the tumor is. Make your first incision away from it. You're going to put a chest drain in, so put a incision lower down, put your finger in, start feeling the tumor, and start going around and dividing around the tumor, making sure that the good margins are there. So this is important. Don't go into the tumor. So you have planned what are you going to resect and whether you need to reconstruct that. That is again important. So something sitting under the scapula, you don't need to reconstruct. One or two ribs removed, you don't really need to reconstruct, but you're taking one or two ribs at the costal margin, something needs to be done. 2 or 3 ribs over here, you don't need to. So have an idea what you're taking out, how much was that contributing to the ventilation, what was it covering, and then you need to decide when to reconstruct. What prosthetic material? So I can speak for a long, long time to discuss various prosthetic material which is available, but I can tell you, none is better than the other, okay? At the end of the day, whatever you put in, that amount of defect, physiologically, functionally, is going to persist. So all you have to do is just remember the principle that you put something there which is tight enough to remove the paradox, covers the internal organs, and gives some functionality to the chest wall and cover it. Okay, so various sort of meshes. So these are synthetic Prolene, Marlex mesh. It could be various type of biological meshes in the market, and it depends what it is and what the price is. Or you can have a Marlex mesh and you can have a cement going in, or you can have a metallic bars, or you can have a combination of all of these. So it's, again, your experience, what you are comfortable with, and what sort of patient it is. So if there's a lot of infection there, then probably you'll be keen to use a biological mesh. Okay, so it's what you are comfortable with and how you envisage what the three-dimensional picture is going to be after the reconstruction has been done. You need to do that. But the problem with these various metallic stuff is that there's lots and lots of papers recently, people who have used them, they find that they break. And the incidence is anything from 40 to 60%, and that is our experience as well, that within a year, when your patient comes to you for the follow-up, there is a cracks in one or two of them. And we have taken a few of them out, and we have left them after taking, because once you have put them in, the periprosthetic fibrosis and everything which happens really, I think, helps to make the areas relatively stable and stiff, and you can take it out. But it has to be removed, and that is a pain. To remove them is really, really, really difficult, particularly these ones. So this is another kid on the block, the three-dimensional prosthesis. Again, as I said, whatever you're comfortable with, use it. But at the end of the day, nothing is going to restore the functional integrity of the chest wall to the normal one. So there will be some defect somewhere. But again, it is the price. And this one is about 10 times more expensive than the ones I showed you earlier. And that's what they look like. So they all look pretty good. As I said, whatever you want to put in, have a normal looking chest wall at the end of the day. Okay, so soft tissue cover, as I said, is important because it allows you to be very radical. You can make a huge defect, and you'll be comfortable that your plastic surgeon will be able to put some sort of soft tissue on it, and that will help in all that. And again, as I said, broadly, I think it depends on whether you're creating a skin defect or not creating a skin defect. You can have various type of flaps. And again, you don't need to worry about it, how you're going to take it out, because you should have a good plastic surgeon to do that. And again, which soft tissue depends the age of the patient. Somebody who's 75, 80 years old, you would not like to really do a free flap on it. Somebody who's a smoker, has been smoking quite a bit, as atherosclerotic, you'll be worried about it. So age, other comorbidities, where is the defect, whether it can have a free pedicle graft or a free flap. So all those things are important. But this is again important, whether the patient had some previous operative procedure performed, the patient had a radiotherapy, you need to be mindful of the fact that the tissues are not going to be very good there. So just to give you a few examples, for example, this is a patient with a chondrosarcoma, and that's where, as I said, the biopsy has been taken. So incorporate that in, remove it, fill it up with whatever you feel comfortable with, repair the diaphragm defect, and because you're not losing much skin, it can have latissimus dorsi muscle flap. Now this one is actually angiosarcoma. Again, it creates a big defect, and because there's a lot of skin defect, you need to have myocutaneous flap. So from just the muscle flap, you now have moved on to the myocutaneous flap. Then you have this one where you're going to create a defect, and the defect is quite big actually, and not only you need a latissimus muscle flap, but you may also need some sort of skin graft on the top of it. So what I was trying to tell you was that this is a patient who has got a recurrent synovial sarcoma, had a lot of radiotherapy given to this area before, and you know that area is not going to be good because of previous radiotherapy, and so you actually use pedicle tram from the front and take it to the back. So think about all these things, and you can work around it. So I'm not going to take you through all that, but I just want to. So this is again various types of, as I said, prosthetic material you use to repair it. The only one I'm going to just take you through this is again this is right in the beginning of our experience. We were trying to minimize the amount of cement we were using, so we were just making thin layers and then making the holes in these layers and then trying to fix it to the rib cage, and it worked. And this lady still keeps coming back to us and doing quite well. And this is amazing. I mean, this guy was going around for 4 or 5 years with the whole thing fungated. The whole chest wall actually had to be removed. And what can you do about this? Again, think about how this patient is going to be and what you need to cover this and how you can make him breathe reasonably well, and what are you going to use because of ongoing infection. So what he had was a big biological mesh, and then we used these titanium stratos bars to fix it, and then you got a fascia lata from the leg and put it free graft over there. So what I'm trying to say is that even that big ones can be dealt with. So the last one is, so this is again another one. This is a patient who had a very high-grade pleomorphic sarcoma presented with a pleural fusion, and unfortunately had a chest drain inserted into that. And then when the right lot of blood came out, that is not something really right. And again, you need to then, because there's a chest drain going from there, you have to modulate your skin incision. And this is, as Prof said in the morning, Prof Kasivi, about the spinal surgeons getting involved. And again, two things. One is the collaboration with the spinal surgeon. And number two, the defects at the back, you don't really need a fixed, rigid reconstruction. So all this patient required was just a mesh and cover it with nicely. Now this is, I'm just showing you because this is before the proton beam therapy, that this is a patient with Leiomyosarcoma will need a radiotherapy to that area, and you're worried about the kidney, the colon, and other stuff lying there. So here what we did was that once we had removed the defect and covered it, we put a tissue expander here and filled it up. And the patient completed the radiotherapy, came back, and all we had to do is just give a small nick, take it out, and protect it. So you can see that's a tissue expander line there, and that's once the patient had finished the treatment. And this one, as I said, looks very subtle, but this is a very, very wrong place because it is right at the lower end. You repair it, and then you need to cover it with various soft tissue flaps, and that's where the struggle is. You can't get back major there, so you have to mobilize, for example, the omentum to cover it. So pretty much a multidisciplinary approach to these tumors where you involve various teams, sarcoma team, your plastic surgeon, spinal surgeons, and most importantly is the physiotherapy and the nurses in the ward who actually make these people mobilize and take care of the position, keeping in mind what flaps have been used, et cetera, et cetera. And usual post-operative. And again, if you look at the literature, this is what it says. So the results are very gratifying if you keep to the principle I've just alluded to: wide margins and block resection, cover the defect, and put some soft tissue on it. And if you look at this 50 to 70-year survival rate, that is pretty good. So to conclude, ladies and gentlemen, as I said, majority of these tumors are resectable. Make sure that you follow the principles, remove as wide margins as possible, and then cover it nicely. And as I said earlier, if you look into the literature, there is a lot of stuff people have been using, but at the end of the day, it is important that you stick to those principles. And none of these is better than the other. Thank you.
Thank you very much.